integrated right within their EHR. And what's really cool is all of the required information can be attached right then and there without having to drag and drop or move things around. And I think most importantly is it reduces administrative burden, work delays, which is exactly what regulators and providers wanted. And we all know quicker approvals and less hassle for the portal shuffle is going to be a good thing.
Awesome. Amy, Mike, you guys are on the technical side as well. There are three APIs involved in these new prior authorization workflows. Between the two of you, help our audience understand what these three APIs are and why they are important to providers. And either one of you pick up and start.
Some might come off mute, but I'm ready, Mike, if you
Yeah,
like
go
me
ahead.
to.
Go ahead.
Okay.
Yeah.
Okay. With the three different APIs that are involved are one, you have the patient access API. This isn't new. This is one that payers have had to have in place for several years. The idea behind the patient access API is to let patients access their health and coverage data using an app of their choice. So they go to their app store, select one that looks good to them, and that app then connects to the payer's API for patients. The added portion of this is having the prior authorization data also included in that patient access API so that the patients have some transparency and visibility into what's required. Then you have the provider access API. This allows our providers to request and receive patient data from the health plans with the idea of supporting better care coordination. And then we have the specific prior authorization API. This is supposed to streamline the prior authorization process by allowing our providers to submit requests and receive decisions electronically directly from their EHR, as Jen was saying, or your practice management system. So this isn't having your fax being converted into an electronic format. This is truly navigating through your EHR, grabbing the information, sending it to the payer so that the payer can make a determination and send it back to you. And ideally, that happens quickly and not have long turnaround times.
Awesome.
Mike, you have anything to add?
Mike, do you have anything to add to that?
Well, I was just going to say really quick, just as an intro, my name is Mike Farabee. I'm Deputy CIO for Medicaid Services here at the
Give me,
Healthcare
Mike.
Authority. That's okay, Jim. I was a late entry, so that's why I'll do my intro now really quick. I've worked here at the agency for 20 years. The last 5 to 6 years has been a lot around interoperability. So I helped implement the patient access and provider directory APIs that Amy mentioned. I'm also the co-sponsor for our prior auth API development work. But prior auth for us is not the only API. We have those other APIs that Amy mentioned as well. So definitely a lot. CMS has ramped up now. The amount of APIs that we'll need to implement. Of course, for us, we are implementing, the healthcare authority is implementing APIs for our fee-for-service population. And of course, our managed care partners, CHPW being one of them, are implementing for our managed care population. So definitely taking a lot of coordination between HCA and our partners. And we've also been spearheading the effort that Jim mentioned at the beginning around the collaborative that has been happening over the last year, which has been very exciting. So a lot of good will come from this as we continue to move down the journey of interoperability. And so, but definitely a lot to implement as well within the next 18 months.
Okay, awesome. Thank you, Mike. Angie, let's go to you. Which types of health plans are directly impacted by these regulations? And then there's a twist to that, and maybe Jen and Mike will be able to talk to us about the non-regulated aspects of these rules.
Thanks, Jim. Yes, so the health plans that will be deeply affected are those government lines of business, if you will. So Medicaid, your CHIP services, Medicare Advantage, as well as any duals populations, and qualified health plans on the federal market. So with that being said, those particular services that are covered there's a wide range for medical services typically that require prior authorization, your hospital stays, your outpatient procedures, outpatient surgeries, specialty services. The majority of those are going to require a prior authorization. And some of those other lines of businesses, if you will, or entities that could be affected are your pharmacy, benefits, dental, and vision. Some of those procedures also might require prior authorization. And then also, as you look at carve outs, a lot of times they are very well state specific. So it's important that the providers check with the health plans for details around those. Thanks, Jim.
Awesome. So I mentioned, like Regents, you have some impacted plans, obviously, but you also have plenty of health plans that are not specifically called out in the regulation. The use of APIs for some plan PAs, but not for others, could create confusion for providers, but many insurers have stepped up to address this. Talk to us about this aspect of the modernization and prior authorization.
Yeah, you're exactly right. So the mandate, right, is definitely going to impact our Medicare lines of business, but we have commercial and self-funded groups that are not impacted. A mixed approach just isn't going to work. It's not going to work for anybody. We don't want staff playing the little shuffle again between do I go here, do I go there for the same plan? So we've taken the approach, and I'm assuming many other insurers are going to take the same exact approach. We're rolling this out to all lines of business. Our goal isn't to cause more tyranny or create more confusion. We want to have a seamless, streamlined prior authorization process that's going to work for everybody and all of our lines of business. Mike,
Fantastic.
do you have anything? Oh,
Mike?
sorry.
No, that's all right.
Yeah, I mean, I just wanted to weigh on this one, but just because um, from the state law perspective, so House Bill 1357 that passed, that also requires implementation of APIs. For us, that did not include our fee-for-service population. So, that I sort of wanted to just, call that out is where we're dealing with that on, where we have, those regulations obviously impact our managed care partners, but they don't impact our fee-for-service partners. So we here at the Healthcare Authority are doing what we can to try and ensure that there isn't an inequity situation between our fee-for-service population and our managed. We know that we'll have to implement for fee-for-service for the federal rule, right, by 2027. But the state law, of course, was much sooner. And, so, there definitely is, even on the government side, differences between the two populations that we oversee for Medicaid.
Awesome. And I'll just add that all of the national health plans and the entirety of the Blue Cross Blue Shield set of health plans and others have signed on to addressing these APIs across all of their lines of business. So I think that's a really important aspect of the rules came out and are important, but they didn't cover everybody, and health plans are coming to the table to lessen that confusion. Dalika and Mike, you jump in here too. Washington State, as I mentioned, has really been leading the country in the development of these regulations and indeed in the early production efforts with the APIs. But aside from the technical considerations that we've just kind of learned about, what other improvements are called out for in the state and, if you'd like, federal regulations? And if there are any significant differences between state and federal, maybe you could highlight those.
Yeah. Also, I apologize if I freeze. My Zoom has been freezing and I've been having to reconnect. So if I go out, sorry about that. Yeah, so like beyond the APIs, generally state law requires carriers to shorten timeframes for standard and expedited prior authorization requirements, make prior authorization requirements transparent and accessible, and to base prior authorization requirements on peer-reviewed and evidence-based clinical review criteria. Beyond that, it requires carriers to build and maintain software that automates prior authorization requests. So the state law on automated prior authorization process requirements incorporates the federal rules. So the federal rules applies to healthcare services covered by Medicare, Medicaid, and health plans offered on the federal exchange. It improves the electronic exchange of healthcare data and streamlines prior authorization processes by requiring APIs. The main difference between state and federal law as it relates to APIs is that state law requires prior authorization APIs for prescription drugs in addition to healthcare services, and they both require implementation of APIs by January 1, 2027.
Awesome. Okay, Heidi, over to you. Tell us a little bit about the Foundation for Healthcare Quality. How do these PA APIs align with your existing administrative simplification programs in Washington and the goals of those programs?
Thanks, Jim. As I mentioned in my introduction, Washington has a long history of coming together to collaboratively solve problems in the healthcare space, convening groups with representation from different parts of the delivery system to look to ways that we can create a best practice recommendation so that everyone knows how to approach a problem and knows what kind of the rules of the road are. We're hoping to be able to do that in this work as well. We've spent some time in previous efforts to develop best practice recommendations along the lines of what Dalika mentioned around the timeliness of processing a prior auth and the visibility for consumers to prior authorization practices. And this is an opportunity for us to continue to guide that work as a neutral convener of kind of that multidisciplinary approach. I think we've all heard throughout this early parts of this conversation that the goal is really to reduce administrative burden. I think that's a big opportunity for us. I mean, administrative simplification is exactly that. Like, how do we make this all work faster and easier and smoother for everyone involved? And in doing that, really doing that in service to the patients who are seeking care to make sure that they're getting the right care at the right place at the right time. That should be our ultimate goal in all of this work. So looking to spend the next few months kind of in that work group setting, doing some matchmaking, putting people together who are ready to do testing on all sides, making sure that everyone who's involved in the process is able to tell us where their pain points are and what they're needing help with, and be able to escalate and share that information to all those parties who need to know, so we can continue to make sure that we do what we can to meet our timelines, and then to develop processes further after our 1/1/27, which seemed like a long way, long time out in the future, but it's going to be here soon. So again, looking to be able to continue the work that you guys at Point of Care Partners started, and bring together both the payers and the providers in a way that we continue to make progress.
Fantastic. That just one more piece of evidence of how Washington is stepping up to the plate to make this new PA world a reality. So thank you, Heidi, and thanks to your organization. I should have said this sooner, but I'll say it now. If anybody in the audience has any questions, feel free to put them in the chat. I'll be looking for them, and if I happen to miss them, if somebody else can holler and let me know that we've got a question in the chat, that'd be great, and we will do that. We have time at the end of the presentation for some questions, but feel free to add your questions to the chat before then, and if we've got some time as we move through the segments of the session, then we'll take care of that. Okay, so we've just covered the regulatory whys and the whats. let's shift more into a practical experience of moving from today's PA world to something more automated. Most of us know the current state all too well. It's phone calls, it's faxes, it's payer portals, it's inconsistent documentation requirements, it's more phone calls, it's more faxes. It's time consuming, it's frustrating, and it can and often does delay care. The promise of new APIs, the new APIs, is to bring us much closer to a predictable, transparent, and scalable set of shared prior authorization workflows. Here in Washington, as we've said, we actually have real world experience to draw from. Multicare and Regence Blue Cross Blue Shield have been live on these APIs for at least a couple of years. And that gives us an unusually rich look into what collaboration and workflow redesign actually look like on the ground. So in this segment, we're going to ask what's changed, what hasn't changed, what has surprised you, those of you that have had some implementation experience, and if anything, and how has codified medical policy helped to reduce the back and forth between payer and provider? So let's do this. Anna, Jenna, you've both been in the thick of this work, as we've said, for some time. How did your collaboration evolve? Has it been all smooth sailing? And what are the fundamentals you would say of working together? Finally, has anything surprised you in your collaboration?
You want to go first, Jen?
Yeah, I definitely can. No
Sure.
problem. Um, and feel free to correct me if I say anything wrong. Just like interrupt.
Yeah. Same, right back
Oh,
at you.
oh. So I think what's most important and pretty cool is that we really set up a close-knit collaboration. And so at the very beginning, we had daily, sometimes weekly check-ins, and we would troubleshoot issues together on the call in real time. And the fundamental there is the transparency and the joint problem solving. So we worked almost as one unit. And I would say today, Anna, that your team and I, we still work as one unit. When we hop on a call, it doesn't feel like two separate companies.
Mm-mm.
We have a shared mission and a shared goal, and we want to make things better together. And so I'm not going to lie, pilot mode is pilot mode, right? And so it's always going to be a little bit of hiccups and some bumps. But I think as we progressed, we built a really nice, steady partnership. And now we have a steady product that's proven, it's trustworthy, and we're getting things done. We're getting it done faster with less admin work and adaptability on both sides of the house to make this workflow work. I do have a couple of surprises in my back pocket, but I'll let you see. I'm curious what you have to say.
Yeah, I'll second that. When we get together, it feels like we're one team. And I think that took time when we first started the whole project. And our team was even, they were learning fire. And we had third party who was also trying to figure out how we're going to write this app, right? And I remember going to interview. I think what brought us together the closest was when we started sharing each other's process. We were like, this was our experience with one of the calls, 90 minutes on hold, fax the thing, get the wrong person, 90 more minutes on hold. And then your experience of like, we didn't get this came to this number. And so it was something that brought us together to kind of share all our pain in this process, and that we both wanted to come together to do it. And I do think that there was conflict because we had to figure out ways where each of us had to change. We had to change who we are and how we did things. And we all were focused on the patient and making their world a better place, and also making our world more efficient. And I think because we came together under that one purpose, we continue to reap the spoils of that relationship that we've built, and also been able to improve our operational efficiencies and really give our patients the resources where they need to be, which is at the point of care instead of in the back end of the office. So I think our people always ask me on these panels, do you think you can repeat this with other people, other payers, like this relationship? And I said, absolutely. Like, we'll come to the table open, curious, courage, connection, passion, all those things. We're going to bring that. And if you bring the same thing, I 100% guarantee we can repeat that model. So I think it's really about people's ability to show up in those ways and to kind of put the we don't negotiate rates in this meeting, okay? Like that's not what we're doing. So that doesn't come into the circle of trust for PA. And we don't let that impact the good work we're doing on this side.
That's
And
good
then
stuff.
yeah, you
that's
want to share surprises, Jen?
yeah, let's do that.
I'm curious if they match mine.
Okay, yeah, let's do this. This is fun. Okay.
Okay. Do you want me to go first or do you want to go
Yeah,
first?
you go first.
Okay, so I was definitely going to address the workflow and the matching what's in the EMR to what to actually getting it to load into a pre-authorization, and then
Mhm.
how we on our side can check certain boxes to make sure that pre-authorization is met. So I don't know if that's necessarily a big surprise, but I think we learned a lot more about workflow and a lot more about practices, like checking for a prior authorization almost every single time. That stat was like eye-opening for us. We had no idea the administrative work that goes into it. I think we've heard, but seeing the data is just phenomenal. Another thing that I think is a surprise, but in a good way, is you guys gave us a laundry list of like a huge long wish list of, hey, this works great. We love it. Now let's also do this, this, and this, and this. And it was surprising, but it was exciting because it's like, yes, this is working. We have the trust. We've tackled this one area. Let's tackle these other areas. And so, I don't know, those are my surprises.
Those are good. Those are good ones. I like them. My biggest surprise out of this whole thing was actually that the paperwork took 2 years and the building and installing of the app took like 8 weeks. Okay, guys, like like the kind of technology we're implementing is low code to no code. You implement an app, you show your people how to use it, you're very smart humans, and they go. It's a completely different way of healthcare to think about installing and using software. We usually purchase these platforms. It takes us 2 years to do this thing, but we came down to actually saying like how much time. It took 8 hours to download and install the app, and then it took the rest of the time to educate people to use it, and that was it. So it's a very low barrier to install, but because of the way HIPAA is written, we had to do a bunch of paperwork in order to trade a X12 transaction in a FHIR API. Since then, we have been able to get the exception in place and also get the discretionary enforcement. And now we have 0057. So those things are going to reduce paperwork, but I don't think there's any way around a trading partner agreement and some sort of level of a BAA because of legalities that we just have to put into place. So my hope is that from that surprise, we can create documents or items that can help people speed that up so it doesn't take as long.
And we have, just to let you
Yes,
know.
that's
So
awesome.
you're right. I'm going to be honest here because we're all friends, right? So
Yeah.
the legal documents, we currently have a template for a trading partner agreement, but getting our provider partners' legal teams to review it and agree to it and just get it in front of their desk because they have so much workflow or
Mm-hmm.
workload, that that is a barrier and that does take time. And then you're right, the implementation itself, we say roughly about 20 hours, like you said, the actual implementation and then the training. And what's really cool is since I've started really helping with this for about the past 2 years, I haven't had to train any of our provider groups that we've onboarded. I give them a
It's so
simple
easy.
PowerPoint.
Yeah.
Yeah, it's so user friendly. We try to match it and have a very close parity with our payer portals today, so that way it's not a big, heavy learning curve. And so I like that you say that. I'm sorry that we went through that long
Oh, it
process and
was
had
you.
to get
It
that
was everyone's
exception.
problem, not
Yes.
just yours. It was just teaching our legal team what why are we doing a trading partner?
Yes,
This is why.
exactly.
This is the new
Yeah.
era coming into our trading partner era. Yes, so it
Yeah. It
it
still takes time, but it's
it
easier.
does. And hopefully we're speeding it up for other people because we teach them what to do.
Yes.
Ladies, that's pretty exciting stuff, except for the trading partner agreement part of that. So that's very encouraging, I think, and hopefully our audience is taking some of that to heart. Angie, in our conversations, you have uh, said that efficient prior authorization isn't just about APIs, it's about clinical necessity and the supporting documentation. So talk about the importance of this and how the new APIs and this thing called codified payer medical policy can help ease this challenge.
Sure, Jim. It is key for prior authorizations that we have the necessary clinical documents that support the medical necessity for the procedure that a provider might be requesting for a member. It is ultimately our responsibility in healthcare today to ensure that the requested care that our members receive or that our providers are providing is medically necessary and it's supported by evidence-based protocols and guidelines. One of the great things about the APIs and the interoperability components is that we will have guidelines that are automated. So when a provider goes to submit a request, it's going to bump up against those guidelines and it's going to give them instant, and hopefully the ultimate outcome would be it would give them instant prior authorization. And we would be able to reflect that back to the clinical criteria that is necessary for that prior authorization.
Awesome. Anna, back to you, and maybe you can speak a little bit to your experience with that piece of it, but more broadly, from an organizational and a process perspective, what have you found changes versus stays the same? I'm pretty sure I know your answer to this next question, but is there a one size fits all approach for providers?
I think I mean, I call providers or clinicians my skeptical scientists. I'll start with that question first, because you have to earn the trust, and rightfully so. They've been taught to look for the evidence, make the best pathway, and that enables them to make the best decision they can with the patient and with the information they had at the time. So I think the one size fits all is elusive because it's something that a patient is unique, a human is unique, and the people actually doing the work, which there is a human in the loop for this particular thing. There's usually two. You need to be able to work as a human, which means we all do something a little bit differently. You type the B with this finger and not this finger on the cat. Yeah. So we're all different and unique in how we do things. And I think that there isn't a one size fits all. But what there is a standard in technology that enables us to say, hey, this tech gets into place, and then I get to choose how I interact with it. A lot of providers have been saying, I want this in at the order launch. Like when I'm ordering an MRI, I want the logic to launch. And some of them say, nope, I want my back office staff to do that. So I think that there's not a one size fits all, because what makes provider organizations unique is their culture and the way, and that's kind of like the market competition is, and our special sauce is that this is the way we care for patients. This is the way we connect with our communities. And that's going to take some unique workflows that we do, but we're going to take standard ones. And then as humans, we'll incorporate them. And that's what gives us the cultural fabric of how we perform in healthcare. So that's what I think, one size fits all. And then about changes versus stays the same, I think that here's what's something really interesting that happened too. So another surprise, but also answers this changes versus stay the same. We've been trying all sorts of different solutions to solve this problem because we don't just have regions, we have multiple payers that we would like everyone to use this capability. But it took a long time to convince my rev cycle team that this was going to be the game changer. We went through trying to solve the problem with screen scrapers and apps that were native to our EHR and other capabilities that automated putting the data into the portal for you. So basically agents that would go out and little robots that would do it. But because those forms and the codes change constantly, those would break. So then you're constantly paying to recode something. And it wasn't a financial model that was good for us. And they realized, that's why it became known as the magic button, that, oh, this is what Anna's talking about. Can you get the rest of the payers to do this too? Can I get some more magic buttons here? So I think that meaning they had to adapt to this new workflow. They were thinking, oh no, this is not going to solve it, but they really liked it. They were like, wow, it's so fast. 94% of my inquiries I get in a 30-second response or less. And then they would be like, okay, but I'm going to do this screen scrapey thing. But then it kept breaking. And so they were kind of like gravitating towards this change. And so I don't think this totally changes the game for us because it's pulling data into the EHR. We're getting a human in the loop. Things are going to be more accurate in the future because we're having, that double check. And if you're thinking about safety science, 1 in 10,000 mistakes a day a human makes. So if you have a cross check, 1 in a million, that mistake will happen. So the agent and this API become your cross check, which means we're going to be multiplied in order for our reliability in being able to send the right data that matches the utilization policy the first time through. So I think things are going to change from that sense. And who knows what that means, because that's just like solving problem one. And what maturity will that lead us to? Hopefully more evidence-based medicine. But I think those are the two things that answer that question.
Yes, thank you. And you helped me understand that over the last number of months in ways that nobody else had. So I appreciate your insight and you're pushing me along on that, Anna. Thank you.
Yeah.
Okay, we're more or less on time, maybe just a couple minutes behind schedule. We're going to shift a little bit into a conversation about realistic expectations. Even with the new rules, 2027 is not, a flip of a light switch. Provider adoption will depend heavily on EHR vendors, payer readiness, internal capacity. So this is our kind of straight talk segment. We're going to look at what the early implementers have learned, where they ran into obstacles. Were there any invisible problems that slowed things down? We've maybe already heard about a little bit of that. And we're also going to inquire with our state regulators on the call how they're thinking about expectations in the early years. The goal here is not about perfection. Really, it's about honesty about what we can expect in 2027, 2028, and beyond. So let's get into those realities. And I'll stick with you. Based on your implementation experience and the lack of any immediate regulatory requirements for providers, for EHR vendors, what do you think realistic provider adoption looks like in 2027 and 2028? And then we'll open that question up to others on the panel.
Yeah, that's great. And I think, Jen, there's a question in the chat for you about the APIs. So if you want to answer that first before I
Yeah,
get
yeah, yeah.
started.
Before you
Yeah.
get started, I
Yeah.
love it. So right now, our APIs for Regents, and I can just speak for Regents, we don't have AI built into them. We do have what's called codification, and that's like a decision tree or a table. So if certain things are checked or certain criteria is met, like a certain diagnosis, for example, we know that we're going to auto approve it. So we can give our providers an instant auto approval. If something were to ever deny, it's definitely going to get reviewed by a medical physician, right? So a medical director on our side of the house will review any denial. So nothing will ever be denied by a decision table, for example. But when we can give approvals instantly, we're going to.
Yeah, it's that codification process that happens. So that's about codifying your medical policies into an algorithm that would match it to the data available in the API and any supplemental data that we provide to them too. And we actually get the denial letter with the PDF and the reason why back in that payload. And we're able to access it and attach it to the patient's chart. So there's a human in the loop for this one. But we do, for example, appendectomies. The criteria is pretty simple and so easily codified, that's definitely in the bucket of the 94% that we get back instantaneously.
Awesome. And
Yeah.
Dalika, I don't want to put you on the spot, but there is state regulation around the use of AI in the prior authorization space, and that certainly is happening across the U.S. Do you have any comments you want to offer on that?
I don't have any, I guess beyond like carriers being able to implement this by January 2027, I don't think there are any other like specific timeline expectations. Obviously, we have like the work groups and we have like conversations like these to help kind of broaden understanding and help payers get to compliance. But I think generally the expectation is just January 2027.
Mike, your thoughts on that? The use of AI
Use
to
of AI,
approve?
yeah. So I mean, I can tell you that we are not using AI for our PA decisions here at the Healthcare Authority for our fee-for-service population. I know that there was, I believe it was last session, there was a lot of legislation introduced. I don't know if anything passed that would like sort of ban use of AI for the decision making on PAs. I would fully expect that to come again this session as well. But yeah, I mean, here at the Healthcare Authority, we are in no way using, I mean, we have very few AI use cases overall here at the agency so far, but definitely not involved in our decision making. We have, our normal clinicians and the same steps and same people involved that Jen was mentioning, here. So we certainly there's a huge use case for AI, especially with PA around the documentation. But we're not currently deploying that and have no plans to when it comes to decision making.
Yeah, just to, sorry, piggyback off what Mike is saying. Yeah, there was a bill last year related to using AI for prior authorization. I think that bill is coming back this session. So I don't know the likelihood in terms of like whether or not it will pass, but there's a lot of like conversation around that. Yeah.
Yeah, I would just say from my experience with payers across the country, uh, there is no intent to rely on AI to make these decisions in the early years of these APIs. And I don't know if that means beyond or not, but I think most states are putting uh, some serious regulation at the table to prevent that type of response from payers. Okay.
I can go back to where I was. Sorry to throw you off there for a
Yep.
second. Yeah. So we were looking at what's realistic. No, wait, where were we?
Yep.
What's realistic for provider adoption? So one thing that I will this goes to the payers, which I don't like this at all, is all the other methodologies are still available. And you guys, and hey payers, figure that out, which I don't think is very it's not fair, but it's when you're asking this question about who are you leaving out when you try to improve an administrative process, we still can't leave out the independents who have to use the fax or will never be able to afford in their financial model $7,000 a year more to turn on these APIs. So, yes, it's a faster process, but there still are budget implications to be able to have these capabilities. In the federal rule, in the CARES Act, sorry, not a rule, in the CARES Act, under the G10 section where it talks about the APIs, it says reasonable fees or something like that, something reasonable fees. That's all it says. And so they can still charge you to be able to have these capabilities. And so adoption in 2027 is going to be important because, yes, when you implement this capability, people want to use it. Like Jen had said, you turn it on and you don't even have to teach them because that's how easy it is, like getting an iPhone. Like, oh, okay. I know how to do this. It's very intuitive. And so people gravitate towards things that make their life more joyful and easier. And so I don't think it's going to be hard for everyone to adopt that capability. What's going to be hard is to stop what we used to be doing. And that's stopping what we used to be doing because there's so many payers in the Washington marketplace. If not all of them are using this methodology, it's going to be really difficult to get habits to change unless it's as easy as this experience has been. So I think that it's realistic to think that major health systems will adopt this, but those independents, we can't forget about them. We got to bring them along. We're doing that in our work, in our accountable care organization, in our network of providers. We've been advocating for them. I know that one EHR came back with an exuberant amount of money, and I said, oh yeah? I don't think so, because number one, if you don't turn this on, it's info blocking for this provider, and it'll be coming to you after that. So we negotiated a reasonable price. So we're trying to, do the neighborhood watch aspects of helping all providers adopt this capability. And I hope that everyone here on my panel will help us do that too, because it's so important to bring them all along. And maybe we actually, in my lifetime, will get to smash the fax machine, just like in, what's that movie called? The Office Space.
Office Space.
They go out and they smack the fax machine. I would love to be alive if we can do that for healthcare prior authorization.
Indeed.
For sure.
And
So
I'm sorry.
Go ahead.
I'm gonna step on my soapbox for a second.
Do it.
I'm going to. So I can only speak for regents, right? But we've taken the stance that we as regents are not charging for our interoperability capabilities. And so I don't know, if there is a way that we could just make it free for all so we can bring our independence with us and our roles and just I think about the member experience, right? And how much this can actually improve our population health. It's just I'm going to hop off my soapbox, but I just wanted to say that really what we're doing is impacting people's lives. And if we are purposefully putting out barriers or maybe not crushing those barriers, maybe we're doing a disservice to society. And so I would just like everybody to just maybe think about that and mull that over on what can we do to improve population health. And this is one lever that we can pull together.
Awesome. I guess I would add one comment there. Payers, these are standard apps, right? They're standardized apps and APIs, and payers across the country have access to these apps that they can share with providers if the provider's EHR for some reason is not ready to implement, as long as that EHR can address Smart on Fire apps. So there's multiple ways to skin the cat here, but your sentiments are right on target, ladies. So thank you. I just had ask for other panelists, maybe a couple of you, if you have any, thoughts from your perspective about provider adoption. And if not, we'll move forward.
Yeah, no, this is Amy. For us, we are excited about this opportunity and being able to make things less burdensome on both sides, and we want providers to want to do this work. For us, the majority of our provider network is our community health centers, and they may not actually own their instance of their EHR. And so for us, it's we expect slow adoption in 27, and maybe not anybody really raising their hand. We have about 4 pilots either underway or in discussions with provider groups to test out all portions of interoperability. So that's the attribution, the clinical data exchange, and prior authorization. And I would expect that as 28 gets closer, that we may have more saying, okay, we're ready because our EHR has to be ready. So I love the magic button idea from Anna and at Multicare. Load them up, please. And, let ours be one too, because we want people to push the button.
Yeah.
Appreciate and I think
that, Amy.
Anna, you talked about getting rid of the fax machine. That is my dream as well. And we've talked about that internally. Like, could we restructure our contracts to say, this is the way that you submit your prior authorizations to us? I think that was Angie's idea, actually. So I just said her idea, but it is a dream of ours as well, because we don't want multiple ways. It makes it too cumbersome. And if we can make it easier, if we can help reduce some sort of cost burden, if there is one, right, that is our goal as well. And I would hope that that is what every payer's goal is. So that was my soapbox, Jen.
Keep it coming.
Jim, there are a couple of questions and some discussion that's in the chat, if you wanted to perhaps go through some of that.
Yeah, I saw a question from Dylan, and I think that Anna has answered it.
I answered the first
Do we want
part.
to bring that?
Yeah, I answered the first part, which was it did reduce our backlog, but in Multicare we schedule first, auth second. So there wasn't a huge change in the patient experience. It was more a change in our experience to do that administrative piece faster. So we knew that locked in the schedule a lot sooner than it had before. And then the whole thing about locations, because one thing I learned, which I didn't know about us, is that location matters. So if you change the location, you gotta get a new auth, and being able to do that on the fly is really important and great for OR scheduling, because you can move them around to different facilities since we have so many that are close together.
Okay, and I think the second part of that question was how do you align prior authorization timing with access? Am I understanding that correctly? And did you already answer that, Anna? Or
yeah, I think I answered that. I feel like I got that one. Unless Dylan, you want to come off mute and ask any clarifying questions.
No, you answered it correctly when you said, look, we schedule first and then authorize later, right? I think some of the fears folks have is, nobody wants a ticket to a concert, right, that they can't go to, right? But if your policies are scheduled first, authorized later, that I can share that's unique to multi-care. Other health systems do that, but others don't. So sometimes you run into this timing conflict.
Yeah.
But thank you for answering.
Yeah, chicken or the egg. And I want to say one thing it does do is reduce the risk of having that workflow. So if we're talking about financial risk, it reduces that risk altogether, which is, if we had everyone going through this, we would have very low risk to schedule first. I'll second.
Okay, and how about one more question in the chat that just popped up? Anna, do you know how often the patient has to reschedule? Auth is delayed or denied?
I don't know the answer to that. That would be a Raina question, or the rock star Raina, I call her. But I'd love if you leave your email address in the chat, or you can direct message me, and I can have her follow up with that question.
Awesome. Okay,
Yeah.
we're just a little over on this segment, but I don't want to leave without asking Dalika, what are, from a state perspective, the compliance expectations from the OIC in the early going of this transition, 1/1/2027, the first few months? Can you discuss any timeline expectations that you have for full payer compliance across all payers, across all PAs? What are the OIC's expectations there?
Yeah, so I think, so like I mentioned before, the state law requires implementation of APIs by January 1, 2027. So I think the expectation is that payers would be prepared to implement on that date. We are hoping that so we collaborated with HCA with the support of Gates Venture to form the work groups, and we know that the foundation will be continuing that work. And so we hope that that is helpful in sort of getting payers to that place by January 1, 2027.
Jen, obviously you guys are going to be ready. CHPW, what are your thoughts on that response?
Yeah, we will be ready. So we actually have one pilot right now where we're doing the attribution and clinical data exchange. It's in UAT. We'll be exchanging data in a production environment at the beginning of 26. And then we're moving on to the PA. And so we have our APIs built, and now it's working with our systems to codify all of our policies and that sort of thing. That's the essential part in the work. But yeah, the helpful bit with the state of Washington, Jim, as you said, we're ahead of the game as this in the state because we have the 1/1/26 timeline requirement up until July of this year. We were moving quickly to meet that requirement, and we didn't stop. And at CHPW, we don't want to just say we can do it. We want to demonstrate that we have done it by 1/1/27, and we will be there. Confident in Q1 or Q2 of 26.
Fantastic. Okay. So let's transition to a discussion about what you guys can do now to engage and prepare. Even though providers aren't under a regulatory mandate, right? At least not until 1/1 of 28. Your readiness today will determine how quickly you can benefit from these modernization efforts, right? To achieve some of the things that Anna and Jen have talked about. This segment is really all about those practical steps. What to ask your EHR vendor, how to participate in testing with payers, how to prioritize services, what provider readiness actually looks like from the perspective of payers and the early implementers. If you're wondering, what do I actually do when I leave this session, then this segment aims to give you those answers, or at least a peek at them. So let's get into that. Anna, I'm going to start with you again. What should providers be asking their EHR vendor about the PA APIs today?
I think the most important thing to ask is, are you building the capability to do this? Because Regents built us an app that we could install. This is not native capability to an EHR at this time. It will be sooner than later. But things you could ask your EHR to kind of push them to make this a higher priority in the roadmap is, one, I would like to be able to interact with any payer I want. I want the workflow to look similar to this region's workflow where we get to see the codified policy and the matching of the healthcare data. And that enables us to be successful in our work. And if we all go to these EHRs and say that, then they will make it a priority, but they're not going to prioritize it until we all speak up about it. So I think going to your EHR, telling them how you would imagine this workflow. Does it evoke from the order? Can we do it in the back office? Can we do it in the surgery center? Could the front office do it too? Being able to have that flexibility, that configurable capability within the EHR, I think is something that you will want to look into and see which one you want to advocate for, or maybe all the possibilities you're advocating for. I think it'll be really important for you to speak up about that being a prioritization, because this type of capability lays the foundation. This is step one in getting paid before the patient leaves, because once we automate this authorization, it's the same logic as adjudicating a claim. Very similar, very similar. Different data points, but that's just an API. But the foundations, the interoperability highways that are established by this will enable us in the future, I don't know, 10 years from now, to be able to adjudicate a claim. So when I leave a primary care office, I know I paid the $25 that I need to pay for my copay, and I didn't have to wait to get that bill in the mail. And I think I've had a lot of independents say, well, why would I want to do this? And I ask them, well, do you want to get paid sooner? Like this is the future. This is where it's taking us. And it's not just helping providers be able to stay independent and in the market, it's also helping our patients have that access to the care.
Awesome. Okay, Jen and Amy, from a technical perspective, how can providers, how can folks in the audience initiate testing with payers?
Yeah, Anna touched on it. The EHR needs to be ready to either accept, be able to have as a payer, my Smart on Fire app, or be able to connect to my API. And as Anna said, I need the provider's help in getting the EHR excited about doing this work, because it's going to be a lift for them if they aren't already working on it. One would hope that they are, and I think a lot of the big ones are, but we have some others who are dragging their feet a little bit, and so I need the EHR ready to connect with me, and then if the answer is yes, we're ready, then either reach out to all of the plans that you contract with, or pick one that's friendly, collaborative, that that you can get the work going with them. Because once you have one connection going, it is easier to then connect everybody else. Previously there was the one size fits all, and Anna's right. The workflows, how the provider cares for the patient in their office and after, is not a one size fits all, but my connection, because it's a standard format, right? Once you have mine, you should be able to connect with everyone else and have that be your standard. And so we need providers to raise their hand, right? And talk to their EHR, and then be willing to talk to me and come to the table with me, because we want to come to the table with you. So
Jen, what do you think?
100%. I completely agree with what Amy said. And I think that when our provider partners go to their EHRs, I would hope that they would demand that this is a standard functionality or a standard capability, just like entering a diagnosis code into an EHR, just like entering a name or a member ID number. This should be a standard component that's automatically provided as just normal day-to-day life. Nothing fancy, just standard component. Be there no matter what. Can I say no matter what? Just do it. With that being said, though, I think that there's an opportunity for collaboration, right? Let us know what you need, while we're building it. So that way, whatever is being built and catered to you. You already know we have SmartAuth up and running. We're also building new APIs. So, like Anna said, it isn't an app in their EMR, it's an actual portal within their EMR. Um, where the data flows. Data still flows through the app, right? But we want it actually directly connected. So I think if you want to be part of our Smart on Fire app that we have today, or you want to be a part of those direct connect plumbing portals, APIs, give your provider relations representative a ring. What's going to happen is they're probably going to pass you on to me. So you're going to be stuck talking to me on the phone for a while. And we're going to get some calls set up. We're going to talk about what it's going to look like, what you're going to need, what you're going to need to do. Then we're going to play with it in a test environment, just like any pilot, right? The thing is, we got to collaborate. SmartAuth is up and it's running. We are taking a list of wish list items that we want to hear. We found that each provider has different wishes and different demands, which is amazing. These new APIs, we're going to probably have a new set of wish list, right? Because it's going to function just a little bit differently. So just understand that it is a pilot and that we're collaborative partners in making this better for everybody. Key, give us a call, reach out to us, let us know you're interested, and we'll make things happen.
Awesome. I heard one, I think, in kind of innovative solution from a payer outside of Washington, but the same thing could happen in Washington. They know that many of their EHR provider EHRs don't have these capabilities today, so they've put their smart app in their portal. And that way, even without the Smart on Fire capabilities within the EHR, they can still use portion of these capabilities through their portal as these EHRs begin to stand up those capabilities. So it was an interesting solution, and maybe one that other payers in the U.S. will start to pick up. You mentioned collaboration, so it's a good segue into this question. Heidi, you and Mike, what collaboration opportunities exist that you think could drive success with these APIs?
Well, I'm going to say we need to take Jen and Anna's energy and enthusiasm for this process and spread it as far and wide as we can. So thank you both for sharing your experiences and talking really about getting rid of the fax machine. I think that there's not a person on this call who wouldn't join in on that smashing. So, but it's a silly goal, but it actually speaks to the idea that we really need to modernize and get with the program in healthcare. It's a little embarrassing when we still have a form of communication to get things done. I really think that we've kind of touched on a couple of ways that we could think about things differently, like it doesn't have to necessarily be completely regulatory in how we bring change about. Like I think, we've talked a little bit about what are the opportunities maybe in contracting. Jen, you said, how do we mandate something? Like, well, how do you build that into a contract? I mean, Anna, if you're doing value-based contracting, there is an opportunity within those conversations to say, like, this is something that we see as a key ingredient to moving us forward. And how do we make sure that that becomes a standard rather than an optional add-on? So I think there's opportunity within collaboration to think about things and leverage the tools that we have, but maybe in a way that we haven't thought of before. So, really just tucking through those ideas and what would it mean and how do we get the right people at the table so that it's not just our dreaming about something happening, but really making sure that it gets built into the processes consistently and reliably.
Awesome. Mike?
Yeah, I mean, I think for us, so this is where I'll confess, like, we have not started. We have not started here yet at the Health Care Authority for fee-for-service. So, and that comes down to funding, right? So and I think we all are well aware of where our state budget is right now, and so we're crossing our fingers and hoping that this session we will be able to secure the funding needed. In the meantime, it's not that we're not doing anything. We're trying to improve our business processes, our workflows. We're doing some of the behind the scenes legwork. We're not there yet with the technical pieces. But when we are, we'll definitely want to try and model exactly what Anna and Jen have been talking about. reaching out, partnering with our provider groups and trying to accelerate things. And unfortunately, we're just not in a good place right now yet. Confident that we will get there. Obviously, we're going to have to. we with 0057F for our fee for service population, we have to right now by January of 27. The partnership that we've had in the PA work group that Healthcare Authority and OIC co-sponsored in partnership with the Gates Foundation and then also with Point of Care Partners. I mean, that has been a huge benefit. I mean, I think bringing as many payers and some of the providers to the table to help us lay the groundwork has been huge. And that's why I'm so confident as soon as we're able to get that funding, we'll be able to hit the ground running. And, because I mean, I think a lot of us can agree technology is not the hard part here. It's just, some of the other things that we need to work through. But anyway, there's a lot of opportunity for collaboration. That's why it's awesome to be part of this panel. Obviously there's a lot of energy around this, and I'm very much looking forward for us, to be able to contribute to that.
Thank you so much for that transparency, Mike. That's the way this stuff moves forward, for sure. So I'll throw this next question out to really anyone on the panel, and just step up and grab it if you'd like. It would seem that payers and providers are not going to be able to address every service all at once. Maybe that's not accurate, but maybe speak to that, whether or not that's the case. And if it is the case, how are you thinking about prioritizing PAs for this automation? Is it something that is done collaboratively between payer and provider, or is the payer driving it or the provider driving it? How is that happening?
I'll go first with the caveat that, of course, we haven't implemented yet. But as we are doing our discussions with our pilot partners and with Angie, we don't want to break the whole system by releasing absolutely everything all at once. So our approach will be looking at, our highest volume, our highest impact services for the partner that we're working with, and collaboratively decide where do we want to focus first to test out the workflows and the system. So if we're doing it through our Prior Authorization API or the Smart on Fire app, so that we can see how do both sides work, do some PDSAs, and be smart about it, and then open the floodgates. Angie, please correct me if I'm wrong in our approach. But I don't want to break everything.
Right. No, I would agree, Amy. And I think Mike kind of referenced it as well. Financially, we are all a little feeling the pressures right now around that component. So just really looking and not breaking the system. But along with the financial component comes the resources that is needed for the tech support. And we're all struggling with that component. So I agree with you, Amy.
Okay. Anybody else have any thoughts on that before we move on?
I just have a thought for Mike before I lose it, which is, even though HCA isn't physically putting technology in, you're making the transformation. I can't remember, Jen, but when Heidi used to talk about this, she said it was an 8-year transformation for them to get to a codification level and a operations level where everything worked like magic, like it does today. So I applaud you for taking that step to operationally ready yourself for that. And I do think HCA has some levers when it comes to the MCOs and requesting that they have that capability for you. And I also think that the Rule Transformation Fund, we might get something, which maybe we use that to lay the data pipelines down to do the AI. I mean, all you have to say is AI and prior auth to the government, and they're like, yes, we will give you money. So I think there's an opportunity in those things.
Absolutely. I totally agree. I mean, I definitely don't want to make it sound like we're not doing anything, because we definitely are. We've got an entire project that's been running for the last year plus, that we're working on all sorts of things. It's just the tech piece, of course, the piece that I'm responsible for is where we're falling short. But we are looking at other options, and absolutely, I mean, I think, but to what Angie was just mentioning, like that's where we just don't have a group of fire developers sitting here, right? Like and actually that's what I'm trying to actually get here, because that's what we know where we're all going, right? It's all fire, and we need to be able to build that capability internally. I don't want to have to go to a vendor every single time I need to implement a Fire API. Come on, this isn't rocket science, So anyway, but that's where we're falling. We need that influx of resources to be able to get there. Once we get there, I'm confident that we'll be able to implement the PA APIs, the provider access, the payer to payer, and all the others, and then go from there. That's the other thing is we want to look at this not as just a compliance exercise. We want to go above and beyond. And I obviously heard that from this entire group, but we share that same sentiment here at HCA as well. We just need a little money.
If only
that
money
sentiment bodes well.
Yeah, if only money grew on trees.
Right. All right. Okay, so we're heading into our final segment of the night. I want to zoom out a little bit with the panelists. The point of this modernization work, as Mike just said, isn't about compliance. It's about better care, fewer delays, fewer surprises, less administrative burden, really for everyone involved. In this last segment, we're going to talk about what success could look like when we get this right statewide. What early benefits we've already seen, what would right care at the right time look like under modernized PA, and what's one action, maybe from at least a couple of you on the panel, that you could take to accelerate progress in this modernization effort. This is our collective chance to look forward based on everything we've learned tonight. Let's explore that. Maybe I'll start this one with just anyone that might on the panel that might want to respond. What does right care, right time look like to you under this modernized PA approach? And anybody jump in.
I'll go. We don't like the silence. We'll get somebody an answer. To me, I spent almost 20 years on the care delivery side. I wasn't always at a plan, definitely not at a managed care organization. And I worked at one of our community health centers, and I was responsible for prior authorizations. I understand the trouble, the burden. And so for me, when I look at this, it really means getting those approvals faster with fewer administrative steps, allowing our patients to get the care they need without unnecessary delays, having the fear of going in, is this going to be covered or not? And really being able to shift the focus from paperwork to patient care. So get the providers back in the rooms with their patients, spending time with them, having their staff being able to focus there and not focus on doing all of the paperwork. And on the other side, from the health plan side, we can also zero in our focus on those requests that we may need a little bit more information on, instead of having hundreds come in and maybe we only need to review one. That will also relieve our burden as well. And I think make a better relationship between our provider practices and the payer, but then also our members or our patients. So that's where I see it.
Okay, that's great. Let's maybe get to some specifics. Jen, you and Anna have done this. What benefits have you seen so far that might inspire others? Any kind of numbers or stats or just general commentary about the improvements that you've seen? I think could be helpful here.
Yeah, I saw Angie come off mute. Did you want to answer that question first?
No, I was just going to say, Amy couldn't have said that better. It really is that the member is the center of everything that we do, and just the importance of it. It will lead to a large approval amongst our providers and our clinicians, our MDs, being able to have that additional time to really, discuss the a denial if needed, and really work through that possible peer-to-peer process. Because as great as AI is, as great as the SmartFire, all of that is you still have to have that specific scope for clinicians and MD to discuss those cases that just aren't black and white. And for those of us that have worked with CMS for a very long time, it's not. There's a lot of gray, especially when you're reviewing to those NCDs, LCDs. So yeah. I think it'll be very good for them to be able to have that additional time and support.
Mm-hmm. Thanks, Angie. Okay, so I just wanted you, because Amy had just shared, so I wanted to follow up with that.
Sure.
But as far as the results that we've seen to inspire you to want to do this, or at least start talking to your payers, are you doing this yet? Can we do it together? It is that we have seen a productivity increase of 233%. And that's with over 12,000 transactions, or actual auths, not transactions, because there's more than that we've done over the past several years. 94 of those have been auto approved or said, oh, no auth required. And then the rest, a pen for a human, which we usually get within less than 24 hours sometimes. And then there's a very small percentage that take a little bit more time, probably the more complicated ones. But it's been really impressive. People don't believe what we're doing, even though we go out and show, look at the demo, this is real life. They still don't believe it because it's just like so exponential. It's like skipping a bunch of problems. So I've been really impressed with the results that we've been able to achieve as a team of teams. And I think the most brilliant thing that has come out of all of this is the trust that we have now to share business processes in a different way that enables us to move towards a common mission of that patient being the one who gets to get the biggest benefit in all of this.
Jen, I see you shaking your head. Yes. How about you from your perspective?
Oh my gosh. Well, first and foremost, Anna stole all my stats.
Hi.
And yes.
We've memorized them.
And it's funny because MultiCare isn't our only health system that's currently using our Smart Auth application. We have other health systems that are also using it, and they're getting very similar results, which I think just speaks volumes. I think, like you mentioned, the collaboration, payers and providers historically have a little bit of like friction, right? And rightfully so. I completely get it. I used to work in customer service back in the day. I get your concerns are valid. But this is an area that we can really come together on common ground and do something that has a meaningful impact. And so I know we talk about stats, we talk about productivity, but I think it's really cool just building a relationship on something that we both want to accomplish and we can do it together. And I think that sheds a new light on I don't know, there's trust, right? There's respect. We actually now have a platform to talk and collaborate and listen to each other in a new way. And I love stats. I love saving money, don't get me wrong, but I also love relationships. And I think this is a really nice way to form a new relationship between the two of us.
Yeah, so well said. And if there are payers on the line, if you think that your medical policy is secret sauce and we don't know it, we already know it. We have spreadsheets that we track them all on. we already know. So there's been a lot of concern, like, oh, they're going to know the medical policy, and then no, that's not sharing trust. So I think that there's just a whole new mindset to say, all right, we're just going to share it all, and that's going to level us all up to the next thing. And in the meantime, we give the patient better care, we all save money, and we give the joy back to the people doing the work, which feels like a win-win-win for the entire situation.
Well, and isn't there transparency law out there? So
Yeah,
I
there
mean,
is. I mean, why fight it? Like, I don't want your dynamic form. I want the whole thing all at once. So true.
All right. Wow. We're kind of at the audience Q&A session. We'll open the floor for any questions. If there are any left, feel free to come off mute or drop another question in the chat if you have any last things remaining. Okay.
Awesome.
So guys, you made it through quite a long session, both panelists and our audience. You know, what we've talked about here is not simple work. In a lot of ways, it's a major shift in how prior authorization is going to function across Washington and across the country. What makes this effort unique is a lot of what you heard about today. We're genuinely approaching it as a shared journey. It's not a payer project. It's not a provider project. It's something that will only work if we move it forward together. And I think you've really heard that tonight over and over again. If there's one theme tonight, I would also say it's that providers have agency in how this transition unfolds. The questions you ask your EHR vendor, the conversations you begin with your payers, the choices you make about which services to prioritize, as Amy mentioned earlier, those decisions are going to shape your operational experience with this new way of conducting prior authorization. I want to thank you all for attending. I want to thank you for your participation this evening. A special thanks to our panelists. Thank you, folks, for being here late into the evening. Thank you for the transparency, the stories, your practical guidance that you shared tonight. I also want to offer a huge thanks to our friends at HIMSS and ACHE for hosting the discussion, bringing this thing together. In closing, and in terms of next step for the Washington State work groups, we're transitioning to a foundation for healthcare quality-led effort. Thank you, Heidi. Where we'll bring providers, payers, and tech vendors together for, as Heidi mentioned, some matchmaking, some implementation support. In this new form, our payer and provider work groups in the state of Washington are merging into one work group. And we're all committed to supporting your prior authorization modernization journey. So if tonight raised questions for you that you want to explore further, that you need to think about before you raise them, we encourage you to keep this conversation going with your payers, with your vendors, your internal teams, and your provider peers across the state. The work really starts now, and your engagement as providers truly matters. Thank you for joining us tonight. Have a lovely rest of your evening.
Thanks, Jim, for facilitating. This was
Thanks, Jim.
fantastic.
Thank
And I
you.
think we need to do a repeat. This is a great panel. I'm going to submit us for something.
Right.
Go
Thank
on
you,
tour,
folks.
guys. We'll go on tour.
Go on to our.
Thank you.
I'm bringing you along with me.
See
See you
you.
later.
Bye.
Yeah.
Bye.
Bye.
Bye.